My name is Brigadier Amjad Akram, so I was waiting for the moderator, but since she's not here, I think we're getting late, so we should start. So I'll call the first speaker, and that is Dr. Madhia Rahman, and she will talk about management of CSCR with subthreshold laser.
Assalamu alaikum. So today I'm going to present a case that was managed with subthreshold laser. So just a little bit brief introduction of what CSCR is. It is an idiopathic disorder characterized by localized serous detachment of the sensory retina at the macula secondary to leakage from the choriocapillaries through one or more hyperpermeable RPE sites. It is usually unilateral and may be associated with pigment epithelial detachment. There is relative preservation of visual function despite prolonged separation of neural retina from the RPE layer. So just quickly moving forward towards my case presentation. So the management options include observation, corticosteroids, intravitreal anti-VEGF agents, laser, photodynamic therapy, and their other case reports show benefits with variety of agents including aspirin, beta blockers, mifepristone, eplerenone, but control assessment is limited to date. Regarding subthreshold laser, to the RPE size has shown good results in several studies and is associated with significantly less retinal damage on OCT than conventional photocoagulation. So there are a couple of studies being published, one in 2015, and that showed the report that the efficacy and safety of micropulse sub-577 yellow laser in the treatment of non-resolving CSCR, and the results show that it is a safe treatment option available. There was another study being published in 2020 in Therapeutic Advances of Ophthalmology, and the results were similar. So we received a case, a 36-year-old male who was diagnosed as a case of CSCR, and he came with a complaint of gradual onset paleness, decreased vision for the right eye, both for the distance and near, for 2 years. Past ophthalmic history included that he had already received 8 injections anti-VEGF bevacizumab on monthly interval, and then history of 3 injections anti-VEGF ranibizumab. In the left eye, he had a history of 4 injections anti-VEGF bevacizumab. The systemic history included that he was non-diabetic and non-hypertensive, and there was drug history of tablet rifampicin since 1.5 years for 3 months. Family history was not significant. On examination, his vision was 618 in the right eye, and near vision was N8, and the left eye was 6.6 and N6. The rest of the anterior segment examination was normal. So the ophthalmic record that the patient had, on 3rd March 2020, he developed CSCR, which is quite prominent here. The central macular thickness of the right eye was 643. That of the left eye was 249, which is quite normal. Now here we can see the patient received 3 injections bevacizumab, and the follow-up was done after 4 months. And we can see that the CSCR, the SRF, it's still there, and not much of improvement was there after 3 injections. So the central macular thickness was 643, and after 3 injections, his central macular thickness was 546. So still just 100 micrometer SRF resolved after 3 injections. So this is a picture of the left eye that the patient had, which is quite normal. Central macular thickness was normal, 250, almost in both the left eye. So after 8 months, on 18 November, the patient came to us, not to us, but the ophthalmic record that the patient showed, his central macular thickness was 552 after 8 Western injections. Now this is of the left eye, which looks quite normal, but in the third picture, you can see that he's starting developing CSCR in the left eye. Here is quite prominent where he started developing CSCR in the left eye. So then he went on to receive 3 ranibizumab injections, and the follow-up was done after 11 months. His CSCR resolved, and central macular thickness was 224 in the right eye. And for the left eye, patient went on to have 3 injections bevacizumab, and after 3 months, his CSR resolved in the left eye. This is a picture for the left eye. So after 9 months, patient came to us with vision 618 in the right eye and 66 in the left eye. So this was the picture when the patient came to us in December 2021. His central macular thickness was 435 and that of the left eye was normal. He was then lost to follow-up, then came back again after 3 months and his central macular thickness is still, in fact it has increased to 483 in the right eye. The left looks normal. So this was the fundus picture that we had. We can see that the macular reflex is altered and the retina seems to be elevated at the posterior pole. Left eye looks normal. We went on to have an FFA being done. This is for the right eye, different stages, choroidal phase, arteriovenous phase. Now here we can observe that there is, along the superior vascular arcade, there's a leakage that is developing in different phases. This is a composite view that is increasing in size and intensity. In plot pattern can be seen. And this is for the left eye. This looks quite normal. So we went on to do right eye subthreshold laser, micropulse laser on the leakage areas. Power was 30 microwatts. Exposure was 10. 140 shots were being given, and the spot size was 100 micrometers. So just after a month, we repeated an OCT, and his central macular thickness decreased from 483 to 270 in just single setting of subthreshold laser. And for the left eye, that was normal. And then after a month again, it was allowed, the retina was allowed to resolve, the SRF was allowed to resolve on its own. And here you can observe that the central macular thickness further decreased to 172. But there's still the red flag area that is prominent here in the lower picture here. And unfortunately, after a month, the patient started developing recurrent CSR in the left eye. So we went on to repeat the FFA for both the eyes. This is for the right eye. Different phases. You can see that there is a leakage area that is over here. It is increasing intensity and size. And for the left eye, different phases. So there is a leakage area here that is developing in the left eye. It is increasing intensity and size. So basically this was a reason why the patient developed CSR in the left eye. So we went on to do a right eye loading subthreshold laser. Power taken was 40 milliwatts, exposure was 10, spot size 100, and 15 shots was given to the right eye. And for the left eye, we did a subthreshold laser. Power was 40, exposure was 10, spot size 100 micrometers, and the shots, there were 22 being given. So we repeated an OCT after a month. And for the right eye, since we did a loading dose, so you can observe that the central macular thickness has decreased and there's still this red flag area is there. And for the left eye, it was 641. And when we went on to have a subthreshold laser, it decreased to 205. So you can appreciate that there is 400 micrometers of SRF resolved in just a single setting of subthreshold laser. So we did not go into the cycle of injections again, and we actually got the therapeutic benefits without producing any iatrogenic damage to the retina. So this is a recent OCT that we performed. So retina is stable. There is no SRF in both the eyes. So his visual acuity improved to 6.6 and N6 in the right eye. And the left eye was quite 6.6 as well, and N6 in the left eye. The rest of the anterior segment examination was normal. So ending my presentation with this hadith of Sahih Bukhari, which says, there is no disease that Allah has created except that He has also created its treatment. Thank you.
That's very nice. Just one pearl for the residents. If you want to memorize the indications of lasering the macula, just keep in mind you always laser a wet macula. There is no indication to laser a dry macula. So if you remember that, that will be putting less burden on your memory. Okay, so the next speaker is, okay, So it's Amir Awan. He will be talking about shifting paradigm of wet AMD management with Paginax. Is that how you pronounce it?
Paginax.
Okay.
Yeah, that's right. So that's brief introduction and no financial disclosure. That's fine. Take. Okay, so when we are managing wet AMD, the considerations are, so there are a lot of wet AMD patients, and if you look at greater than 50% of the eyes had residual fluid even after 2 years. So fluid still persists, and if the fluid persists, that means that the vision will remain poor. And greater than 50% injection in year 1 were given more often than every 8 weeks. So quite a frequent dose of injection is required, although we know that it's treat and extend. With Eylea, we can go up till 8 weeks, but still it's quite a high number. And even in year 2, 44% were given more often than every 8 weeks. I think other problem which I think all over the world and we also face is adherence to the treatment. And if we look at that, up to 60% are non-adherent at 24 months follow-up. So which means that a lot of patients will not come for injection. If they won't come for the injection, fluid will come back again and it will remain there. They will develop a long-term damage. So 3 types of fluids very important when we are managing these patients. Fluid within the retina, which can cause damage to neurosensory functional deficiency, and it can lead to cystoid degeneration and subsequently visual loss. Fluid underneath the retina, either it can be subretinal fluid or sub-RP fluid, which also shows early sign of the disease. And we all know that, especially in the occult CNV, the leakage starts at the level of the choroid and then eventually it affects the retina as well. So it's very important to assess the fluid when you're managing the patient of wet AMD. So how Paginax is different from other molecules? Well, one thing is that it binds all isoforms of VEGF-A, which is really important. It's a small molecule, which means the quantity, if equivalent to aflibercept, it has got 12 times more molecules available. So it's more potent and more effective. There are a couple of trials which were initially done, Hawk and Harriet, on Paginax, and they were at 408 different sites, either in America, which North, Central, South, Europe, Asia, Japan, and Australia, and that were properly IRB reviewed trials which were done. And what they found is that it gains robust vision with Paginax, and it outperformed aflibercept in achieving significantly fewer patients with intraretinal fluid or subretinal fluid at week 16 and 48, which is a significant thing. Another thing is that it dries faster. If you look at greater than 75% of the patients reach sustained dryness by week 32 and 20 by Paginax, and by week 56 and 52 with aflibercept in both Hawk and Harriet trial respectively. So quite significant difference. Fluid dryness is very quicker in case of Paginax. So another dosing phase, few patients on Paginax had disease activity in comparison to aflibercept. And significant number of patients maintained Q12 weekly injections after initial loading dosage through week 48. So here, basically the vision is shown in Hawk and Harriet trials. And you can see above is the Hawk, which 56% of the patients on Paginax, they were at 12 weeks injection after initial loading doses. And similarly, Harriet around 51%, which is again a significant number. So initial loading doses, and then you can just move to 12 weekly injection. And when I talk about the loading doses, it's 3 monthly injection, and later you move to 12 weekly injection. And even if you look up to the longer term, up to 96 weeks, which means up till 2 years, you can see that maintained at that level. So significant vision maintained if you compare with the aflibercept, but there are fewer injection in comparison to aflibercept. In that case, there were 5 monthly injection, and even later they were 8 weekly injection. So if you look at the superior fluid resolution, Paginex outperformed aflibercept in that case as well and achieved fewer patients with intraretinal fluid and subretinal fluid at week 16 and 48. And you can notice the reference here. So both in Hawk and Harrier trial, you can see that a 35% difference, more percentage of fluid loss in comparison to aflibercept. Similarly, at 48 weeks, it maintained this activity. And even up till 96 weeks, you can see that there is a significant difference between aflibercept and Paginex, to 35 to 37% in both trials. If you look at the central subfield thickness, that again, aflibercept was compared with Paginex, and you can clearly see that Paginex was much superior fluid reduction, which is shown in the green here. And similarly, if you go up till week 48, you can see that it has maintained better reduction in thickness, and even up to 96 weeks. So other important thing to remember is in aflibercept, you are seeing the sawtooth pattern, which means that the fluid is coming and it's waxing and waning, coming and going. Whereas here in Paginex group, you can see the smooth, almost like a smooth level, so which means that the fluid is not coming back again and patient is maintaining better vision. So typical pattern, what you get from starting from the baseline up till week 48. So here you can see intraretinal edema present there. Once after the loading doses, patient's central subfield thickness is reduced, no fluid, and that maintained up till 48 weeks and even up till 96 weeks. If you look at the sub-RP fluid, again, it showed better result in comparison to aflibercept at week 16 and 48. So both Hawk and Harrier trials showed 32% more reduction when compared to aflibercept in both trials. And similarly, at 48 week, it maintained similarly. And even at the 96 weeks, 26% more reduction. So it maintained for a longer duration, but as I mentioned, now injections are 12 weekly. So quite less number of injections in comparison to aflibercept. So it dries faster as well. That's another important thing. More fluid resolution you can get, which means absence of subretinal fluid, intraretinal fluid, or even sub-RP fluid. And that's a Hawk data which is shown. So that clearly show that either at the start, week 4, week 8, week 12, and up till week 96, you can see that greater than 50% of patients achieved sustained retinal dryness by week 8 or 4 with Paginex, and by week 12 and 8. So it quickly dries up in comparison to the aflibercept. Similarly, in Harrier trial, that again showed similar pattern. You can see that the more dryness you can get with Paginex, as was shown in Hawk. And again, time to sustain dryness greater than 2 consecutive fluid-free pattern, which again is important. Sometimes what happens, as we were seeing in the sawtooth pattern, the patient were developing fluid again, and then you were injecting and that was going. Here you can see up till 8 weeks, you can see that Paginex has achieved complete dry fluid, whereas if you compare it with aflibercept, you can see it was achieved at the week 16. So again, significant difference. And that maintained for a longer duration as well. So once you go up till 96 week, you can see. And even if you notice the number of the injection here, 3.3, here 5.4 injections in aflibercept. So this post-hoc fluid analysis, most patients achieved fluid resolution with brolucizumab at each time point to week 48, and this was maintained up till 96. So that was a beauty, that for longer duration, we are maintaining the resolution of fluid. Sustained dryness was achieved faster in brolucizumab treated patient versus aflibercept, and greater than equal to 75% of patients reach sustained dryness by week 32 and 20 with Paginex, whereas with aflibercept, you were achieving at 56 and 52 with aflibercept in Hawk and Harrier respectively. So definitely it controls the disease better, and thereby reducing the treatment burden in wet AMD patient. And we know that the wet AMD is ongoing treatment which keeps on going for many years, sometime for the whole life of the patient. So another important thing is that how many patients achieved 12 weekly interval after loading doses through 48 weeks. So 56% in Hawk and 51% in Harrier, they achieved 12 weekly injections. So about half went through, the remaining had 8 weekly, but half or slightly more than half, they were already moved to 12 weekly injections. And if we look at beyond time, you can see that 85 to 82% probability of patients remaining on Q 12 weekly from week 20 to week 48 onwards. And similarly, that pattern was maintained up till 96 weeks. We can see that the patients were having on 12 weekly injections. Coming to the side effect, I think that's more concerned about, more or less are similar, but I think if you look at uveitis and iritis, Paganix and aflibercept, you will notice the difference. So 1.6% in Paganix and 0.1 in aflibercept. Similarly, iritis was the difference. And that's really important because a lot of hue and cry came up when initially brolucizumab was marketed. So this is a safety review committee which analyzed all the patients, so around 1,080 number of the patients, and they showed that 4.6% experienced IOI with or without retinal vasculitis or retinal vascular occlusion. 3.3% experienced IOI with concomitant retinal vasculitis. They had retinal vasculitis. 2.1% experienced IOI with concomitant retinal vasculitis or retinal vascular occlusion. And if you look at the visual loss greater than or equal to 1580 letters, that is much less, 0.7%. So again, important thing here is that if the patient had previous episode of prior in the last year, prior intraocular inflammation and retinal vein occlusion, they are at the more risk of developing this inflammation, and that can be clearly shown here. If the patient hasn't got any, the risk is 0.32. But if patient had already prior IOI retinal vascular occlusion, 3.97% risk, which means the patient who had uveitis previously, any retinal vascular occlusion previously, they are not the good candidates for brolucizumab. So important thing when you're managing the patient, assess the benefits and risks. You need to discuss with the patient what benefits they are going to get and what are risks. You observe the signs of intraocular inflammation and educate your patients. And respond quickly. If develops intraocular inflammation, you need to respond quickly. So important thing is there are certain contraindications, as I was talking earlier, active intraocular inflammation, active or suspected intraocular infection, or even periocular infection. In that case, it is contraindicated. Please not use it. It is also contraindicated if somebody is hypersensitive to active substance. So that's a visual outcome in retinal artery occlusion patients at last visit versus baseline that's been shown here. And if you look at the visual loss greater than or equal to 5, 10, 30 letters, that again is quite comparable with the aflibercept. So which means that the visual loss is not much. Yes, intraocular inflammation is happening more, but the visual loss is not as much. They all are comparable if you compare with aflibercept. 2-year-old risk of visual loss in brolucizumab patients, that again it's very minimal. If you look here, greater than or equal to 15 letters, it's not much. And similarly, even here, you can see that in all these conditions, it shows that either they are getting inflammation, but if they're managed timely, and that may not happen. So this is again SRC report. Overall rate of visual loss of greater than or equal to 15 letters was similar with aflibercept if you compare it with brolucizumab, and that's around 7.4 or 7.7%, which are comparable to each other. Again, important thing is the time of the onset. So it's initially, basically the initial few months are important. So mostly if you look at the first 6 months, patients are having more tendency of developing intraocular inflammation. So if the patient hasn't developed in due time, there is less likely that they are going to develop later. And we all know that half or more than patients went to 12 weekly injections after initial 3 loading doses, and that kept up till going to 96 weeks. So that's the last year they mentioned about the, that what's the average advanced event rate that was happening there. So retinal vasculitis, they mentioned 5.6, retinal vasculitis plus retinal vascular occlusion 6.7, and overall events of interest can happen 15.5 per 10,000 injections. But visual loss is less. So it's important to respond. As I mentioned earlier, you need to select your patients. If they get any problem, you need to tell them about the sign and symptom. So that's a diagram which basically shows that what are the sign symptoms that's happening when you're offering the patient. And ocular examination and imaging is really important in your patients when you're treating them. And the findings look for is there any anterior chamber inflammation, vitrecell, is there any vasculitis. You need to appreciate it earlier and then treat it promptly. If patient requires topical steroid, manage it with a topical steroid. If requiring systemic treatment, oral or intravenous steroids, you do it. If patient is developing the risk of neovascularization, you need to do the laser phacocoagulation. And in some selective patient, you may have to do vitrectomy if it's so severe enough. So that's the guidance for so it's very important. You need to tell the patients about that. If they notice any increase in floaters or visual loss, they need to report it, look for signs of intraocular inflammation. You need to see the nature and extent of intraocular inflammation. To do your OCT, do FFA or OCTA if you require, wide field sometime you require. You need to do it to pick up that how much the damage is there. And please report it. If you notice any side effects, report it. So it was a head-to-head trial with aflibercept, which is again a very potent molecule, and you can see that demonstrated robust visual gains, outperformed regarding the fluid resolution, faster fluid resolution, and you can achieve Q12-week interval in most of your patients, and it's a well-tolerated safety. So just I would like to share one of my case, which is I think one of the first case in Pakistan in which Paganex was used. So that's my patient who basically had wet AMD with large occult CNVs in both eyes. Initially, patient responded to Eylea, ranibizumab, Avastin, but later developed tachyphylaxis, and the response was getting reduced and reduced, and eventually no response was coming. So that's one eye, the right eye. That's the other eye. You can even see here much hard exudation, fluid here. So after 3 loading doses, so we got it on compassionate basis. So that's the fluid is completely gone. Fluid is completely gone here. And you can see this is the CNV area, basically it remained there, but fluid gone. Vision is around 612 in this eye and 624 in the left eye, which was reduced previously. And then 8-weekly injections. So they don't recommend at all to use monthly doses after 3 loading. You have to move to either 8 weeks or 12 weeks. So we gave 2 8-weekly, and then it remained stable, again remained stable, both right and left eye. And now the patient is on 12-weekly injection. And again, no fluid is coming up, patient is maintaining good vision. And this is the other eye. So vision is maintained 6.9 in the right eye and the left eye 6.12. And patient is happy so far, and we are continuing 12-weekly injection. And even none of the time, initially I was more cautious that patient may develop intraocular inflammation. So I discussed with some American colleagues as well, when to follow the patient after. So they didn't develop any intraocular inflammation at all. Thank you very much. So that's a bit of information. Thank you.
Very nice presentation as always. And as I was mentioning for the residents, that you always laser a wet macula, never a dry one. Similarly, this is another favorite exam question, that why the macula is more predisposed to insult. So make sure you know all the anatomical and physiological factors which make the macula vulnerable to damage and insult. Right, so the next speaker is Dr. Irfan Karamat, and he will talk about role of peripheral blood-derived autologous stem cells in patients of retinitis pigmentosa.
Good evening, ladies and gents. I'm Dr. Muhammad Irfan Karamat from Ibrahim Eye Center, Lahore. And I'm really thankful to OSP Center for letting me presenting this this presentation here in this respectable platform. Today I'm going to talk about stem cell therapy in different retinal dystrophies. I'm doing this research in collaboration with Ifan and Anwar Hospital, Lahore, and some of my international colleagues as well. Retinitis pigmentosa, from a long list of chororetinal dystrophies, is a disease of outer retinal layers, giving rise to nectalopia and visual field loss and decreased vision. Worldwide, it's hitting more than 2 million patients and giving rise from involving more than 260 genes, hitting young population and giving rise to peripheral visual loss and to complete blindness, which is giving a socioeconomic burden and psychological burden as well. This was a brief introduction. Currently, we are working on retinal processes, gene therapy, and stem cell therapy in the cases of retinal dystrophies, specifically in retinitis pigmentosa. From here onwards, I would give you a brief background knowledge about the regenerative therapy. Regenerative therapy is basically a broader term which is being defined or explained in terms like embryonic stem cells, adult stem cells, growth factors, leading to different regenerative therapies all over the body. Stem cell is defined as a precursor cell that have the capacity to self-renew and generate multiple mature cells. Two properties: one, self-renew, and second, regenerate into mature cells. When we are talking about stem cells, mostly we think that it's always there to generate into mature new cells, and it goes to any tissue and replace that part of the dead or dormant cells. We mostly forget about the self-renewal part, that it can give rise to self-renewal as well with the help of certain growth factors or proteins. There are different types of embryonic stem cells, like embryonic stem cells, adult stem cells, and induced pluripotent stem cells. Embryonic stem cells are the true stem cells which are harvested from blastocyst. It's there, if you can see that, pointer mil sakta hai? Yes, thank you. After fertilization, we get, after 4 to 5 days, we get a stage which is known as blastocyst. There are 32 to 34 cells. This tissue is known as blastocysts, and these are the true stem cells. These stem cells has the capacity to regenerate and regrow in any different part of, in any specific tissue. Then there's adult stem cells, which are present in in all the organs of the adult human body, like skin. But these stem cells have a very limited capacity of self-renew and regenerating. Third type of stem cells is induced pluripotent stem cell. Mature cells, these are the mature cells from the patient, are treated in vitro with genes that de-differentiate the cell, and it gives rise to a pluripotent stage, which is very close to embryonic stem cells. And this has the more capacity of self-renewing, regenerating. If we classify them, the best one is the embryonic stem cells. Next is induced pluripotent stem cells, and the last one is the adult stem cells. And last but not the least are the growth factors. These stem cells are basically being used in different regenerative therapies to produce certain growth factors. Growth factors are also known as exosomes or trophic factors. These factors go and create that stable microenvironment wherever the disease is, to give an opportunity to diseased cells to start working again in a good condition. What I'm talking about, I'll explain it later as well. I've just written the few examples of growth factors or neurotrophic factors. Now coming back to the example of retinitis pigmentosa within a long list of chororetinal dystrophies. If you look at on a broader spectrum, that RPE is giving rise to ATP production, visual cycle proteins, and manage the waste products for healthy rod and cones. And RPE perform all these functions with the help of these growth factors, which creates that microenvironment, and rod and cones can function properly. Let's say in a certain pathologies, if these growth factors are not there, or RPE is unable to perform its normal functions, what will happen? These healthy rod and cones will go into a dormant stage, and if we do not do anything at this stage, it will go into apoptosis or cell death. This is a typical microscopic picture of a retinitis pigmentosa patient. That this is an outer retinal degenerative part. which in the presence of which there are almost 30% of ganglion cells which are intact and almost 80% of endonuclear layer which is intact. So if we do something for this degenerative part, these cells, healthy cells, can start doing function again. What if in the patient with retinitis pigmentosa, if I inject or give something or growth factors or stem cells on these dormant cells, rather than they're going to a apoptotic stage, they can go back to a healthy stage, and they can help to the patient to function in a better way. Again, this is a healthy retina. It's a retinitis pigmentosa patient retina. This is the where problem is lying. If we give again that microenvironment to this part of the tissue, again we expect, so far we expect that what will happen? Will that degenerative or diseased retina will start working again or not? So talking about the growth factors or microenvironment, which so far I'm talking about, there are different sources for that. One, embryonic source, other is adult source. Embryonic source is, again, I've just mentioned the blastocyst. Second is umbilical cord or Wharton jelly, which is being under experiments from past 4 years. Again, cord blood and exosomes from the umbilical cord. These are the embryonic source. Adult sources: adipose tissue, bone marrow, peripheral blood, growth factors from the peripheral blood. What are the merits and demerits between if we harvest, if we take a stem cell or growth factors from embryonic source? Second is adult source. The first limitation is ethical issues. In Pakistan, so far, there's no body which is regulating this problem or which is dealing this problem. And second problem is threat of induction of inflammation. If we inject such any non-autologous stem cells into a patient, there's a threat that it can cause inflammation. Third, it can be teratogenic as well. Stem cell source of embryonic source of stem cell can be teratogenic. On the other hand, if we get an autologous source of adult stem cells, there's no ethical issue in it. It is not teratogenic, and it doesn't cause an inflammation. But I've just mentioned that there are 2 to 3 different types of adult sources of stem cells. One, adipose tissue, peripheral blood, bone marrow. All of these are quite costly as well. If we talk about to get extraction of adipose tissue from bone marrow or adipose tissue, it costs around $1 million or so for a single patient or for a single eye. This peripheral blood is a very cheap source of mononuclear cells, which is again, it has the capacity of cells renewal or stem cells, which I'll share a study with you. Second, growth factors. This was a study which was published in 2012, in which it was shown that all mononuclear cells from the peripheral blood has the capacity to regenerate or give rise to these cells. And also, these mononuclear cells has the capacity to produce certain growth factors or proteins, which I just mentioned. How we harvest them? You can call it a concentrator harvester, that we take a blood directly from the patient that goes into this machine. Initially, the blood is separated into 2 different parts. One, the cellular part, and second, the plasma part. Now from this blood or blood cells part, it again goes back into the machine, and it separates mononuclear cells from that. This is the part of mononuclear cells which you can just, this bag is for mononuclear cells which get extracted from this blood cellular part. Once we extract the mononuclear cells from the patient, the next big question is how to administrate it into the patient. There are different routes being experimented all over the world: intravitreal, subretinal, suprachoroidal, and subtenon. The first 2 options, intravitreal and subretinal, they they are quite, a lot of complications are bound with these two options, like retinal detachment, subretinal fibrosis, preretinal fibrosis. These are the complications which limits the even the sample size or the international data or research work in administration of stem cells. The next two options are suprachoroidal and subtenon. Suprachoroidal or Lamoulis technique is a simple technique in which we make a window, scleral window, and we reach close to the choroid. Impregnated adipose tissue, which is taken from the orbit of the patient, and stem cells and growth factors are injected in that adipose tissue, and again this window is stitched back. This is known as Lamoulis technique. What you can see is in a single supratemporal quadrant, making a window and putting adipose tissue in it and restitching it again. Now, second big question, that does subtenon route, can stem cells or growth factors pass through sclera? Yes, it can pass through sclera. Jarosky in 2001 showed that growth factors act via tyrosine kinase receptors, which are present at 4 different places. 1, perilimbal region, extraocular muscle insertion, uvoscleral tract, and around the optic nerve. These are the 4 different points at which the growth factors can absorb through the subtenon space. Now, the next big question is that whether these growth factors or stem cells, what's their size? If the growth factors or peptides are less than 75 kDa, they directly pass diffuses. Achha. Is it visible? Okay. Peptides or growth factors which are less than 75 kDa size, they pass through sclera through passive diffusion. If they are bigger than 75 kDa, they need a certain electromagnetic stimulation or a charge on them, which helps into their absorption. There's an instrument which is known as Magnovision, which is just got ethical approval in America. You can online see what Magnovision is. What does it do? It creates a charge, or it gives an repeated electromagnetic stimulation around the eye and around the optic visual axis for a certain period of time, and it causes, because of this charge, the growth factors can pass through sclera, which are greater in size than 75 kDa. We are working on it, and inshallah, hopefully with next few weeks, we'll be able to design our own Magnovision or electromagnetic stimulation instrument shortly. These are the few studies in which these being published in the last 2 years. There's a comparative data on suprachoroidal and subtenon space, the delivery of stem cells and growth factors, and the conclusion is that there are having differences, causing difference on best corrected visual acuity, visual field, and multifocal ERGs. This was a comparative data between suprachoroidal and subtenon space. It was comparable to each other. Again, umbilical cord-derived mesenchymal stem cells implantation in retinitis pigmentosa ensured that suprachoroidal administration of umbilical cord harvested mesenchymal cells had a beneficial effect on best corrected visual acuity, visual field, and multifocal ERG. Another study which showing that subtenon injection of growth factors, just growth factors, in subtenon space in the patients of retinitis pigmentosa, and it has positive effects on visual acuity, visual field, multifocal ERG. In the light of this previous knowledge, we started a study in which we collecting the patients of retinitis pigmentosa, Stargardt disease, primary open-angle glaucoma, open normal tension glaucoma, retinal detachment patients after RD surgery which doesn't have a good visual prognosis, and toxic optic neuropathy. It was a pilot study in which the sample size was 10. In this patient, we harvested mononuclear cells from the peripheral blood and we injected in a subtenon space. The basic method was that we had 2 sessions of growth factors, and after that, 3rd session with mononuclear cells. Another study in which we just injected growth factors in a subtenon space. In this, we had 30 patients, and we experimented or did research on different patients, apart from RP, like Stargardt disease, RD patient, and traumatic optic neuropathy, etc. Our inclusion criteria was not that strict. The data I just shared with you, international data, they had patients with a better visual acuity, like 612 or better. But here in Pakistan, we have a limitation that patients like RP, retinitis pigmentosa, Stargardt, they present when the visual acuity is quite affected. So we had to broaden our inclusion criteria from PL to 660. They had visual field loss, clinically diagnosed cases. Exclusion criteria was that a patient having glaucoma, cataract, or any other systemic problem. Well, this is the data for the first 10 patients in which we injected peripheral blood derived mononuclear cells and growth factors. This is the data of 8 patients. 2 patients lost to follow-up. In the boxes with green color are the patients in which we see a positive result. And the boxes with red are the patients in which we didn't see any improvement. What you can see is that all these patients are, if you look at patient 1, Pervez, he started from patient visual acuity of 660 and ended up in 618 or 624. He had 3 sessions, 2 of growth factors and 3rd is of mononuclear cells. Similarly, other patients, but in these 4 patients which are red in color, they didn't show any improvement after the treatment in 3 to 4 months follow-up. But the good thing is that in all these 7 to 8 patients, there's not even a single patient who showed any adverse effect like inflammation, orbital cellulitis, or any subretinal or intravitreal or increase in IOP. Nothing of such sort was there, and it's a safe procedure in which we can get benefit out of 0 side effects or complications. This is the data in which we just injected growth factors and 2 to 3 sessions, and the patient's green in color got benefit. The patient red in color didn't get any benefit. Got decrease in her vision. This is the only patient which has decrease in vision after the treatment. And the patient in blue or white, they didn't show any improvement. I shared this visual field. This is a pre-treatment, this is a post-treatment visual fields in a patient of retinitis pigmentosa. On a grayscale, you can definitely see a difference within the central part of the central visual field of the patient. And if you cannot see that the mean deviations shifted from -31.97 to -30.16. It's left eye of the patient. In this eye, there's no significant difference, but still there's a visual field changes. This is a patient, another RP patient, in which I have shown a map of macular thickness, in which there is a significant difference between the central thickness, which is around 160, and after treatment is 210. Mean total volume shifted from 5.73 to 7.34, which is again significant. This is left eye, other eye of the patient, showing again a difference in the macular thickness and the central foveal thickness as well after the treatment. Now, what we read and heard that, in the data, it is explained that after the treatment, there is a change in the ellipsoid zone or central macula, or regeneration of certain layers at the foveal level. I've just, this is a patient, RP patient. These are the scans, pre-injection scans, and this is the post-injection scan. What I feel like that maybe it's not that visible on the, from there, but there is a certain regenerative, or there was some disruption in the outer layers of the retina, which got better here in both scans. But I would definitely say that it is not convincing. This is another patient of Stargardt disease. This patient shifted from counting finger to 660. He was unable to read, and he started reading again after the treatment. What you can see that the total average thickness is the same in pre and post, but his central thickness was 104, which shifted to 202. which is being explained in the papers, that after the treatment, the outer retinal nuclear layer and outer plexiform layer thickness increases. Unfortunately, I don't have that much of a good OCT with me, which can classify or which can perfectly show that. But with the help of these scans, I can at least show that there is increase in the thickness in these areas. This second eye of the Stargardt patient disease patient, again increase in the thickness, central thickness, 119 to 194. Limitations were that I couldn't perform multifocal ERGs, which were very important in this case. The inclusion criteria was couldn't be that strict, because our patients we don't have a certain screening criteria in Pakistan in which patient diagnosed in early ages. And what I feel like the patients will have better vision, they respond better. Patients on PL or counting finger, they doesn't have that much of good results. If we, and third was sample size, that we have a very limited sample size, and if we have better resources and we can have with good gadgets, we can perform better as well, and we can have a bigger sample size to prove our point.
Our first speaker, Professor Moin, he will talk about the repair of canalicular lacerations.
So these are typical canalicular lacerations which you would see in patients with trauma, and we have to know the anatomy of the canaliculi, that they have a vertical component and then a horizontal component, and then you have a sac and going in beneath the inferior turbinate. The main important thing is to know the pathogenesis of canalicular injury. Either it can be direct trauma or it can be just because of the stretch of the trauma. So direct injuries, penetrating trauma with glass, metal or organic material, or you can have dog bites. Indirect injuries with fist injury if somebody's in a fight, finger poke, and diffuse injury from impact such as a motor vehicle incidents or a fall. So this can happen in an isolated, you might have a very trivial trauma on the medial side and the canaliculus is damaged, or you might have a massive orbital trauma associated with the injury that could cause this. Usually children or young adults are mostly involved in this injury. Males are more common. Animals or objects may increase the risk of canalicular trauma, and typically the pit bull terrier, that is known to go for this area when it bites, and it sort of tends to produce that. Hooks can be present, either you can go fishing, or it can sometime if you go for shopping in aisles or something, you can get that caught up in your eyelid, or intoxicated persons can end up in injuries. Birth trauma is another risk factor. So when you come in with these patients, mostly it's direct observation with a slit lamp or a loop or microscope, and usually you use a Bowman's probe to find the proximal end, and then you look for the distal end as well. And in young children, or you need examination under anesthesia. Now I think use of a phone or a mobile phone has enhanced your usage in children, because you can sort of engage them in something, take a good picture and zoom it up to see. But still, if somebody's got a small cut or redness, especially in children, you need to see it to identify this problem. So the proximal end is seen with Bowman's probe, and the distal end, you look for the whitish circular tissue, or you can use a fluorescein or air to go through the intact canaliculus. If the inferior is involved, you can inject fluorescein, air, or even viscoelastic, and then comes out through the distal end of the tear, and you can identify that. So this is the proximal end. You can put a Bowman's probe through it. This will give you, and you have to identify how much of this proximal end this is, because when you're suturing this, sometimes your suture can, if this is very small, your suture, if this is big, that can actually sort of cut through that, and this area can go away. So you need a prompt CT. If a foreign body is suspected, CT is more useful, especially in patients with multiple trauma. MRI takes longer to obtain, and especially if it's a metallic foreign body, obviously it's contraindicated in those patients. And contrast is probably not very useful in these patients. Probably dacrocystogram is not used most commonly. And management, obviously it's a multiple trauma. It can be a multiple trauma, or it can be just an eye trauma. If it's a multiple trauma, repair the ruptured globe. repair eyelid margin plus the canaliculi, and it lessens the risk of patient developing scarring. Then I've told about viscoelastic, but topical phenylephrine injury will cause constriction of vascular tissues and aid in identifying of the distal end. So immediate surgical intervention is not required in all cases. It's preferable if you have facilities available and the patient is at the right time at the right place. It's preferable to do that. In retrospective review of patients in Moorfield, demonstrated delay up to 72 hours did not negatively affect the surgical outcomes. Another study demonstrated successful repair as long as 5 days after injury, but the longer you delay, the difficult it becomes to identify the distal end of the tear. That is the issue main with the thing. Monocanalicular laceration may or may not lead to eventual stenosis, especially they say usually if one is not working, you might not develop epiphora. In a study of consultant ophthalmologists in UK, only 40% would always repair a monocanalicular injury. But obviously, if you are working as an oculoplastic surgeon, you would obviously go for this procedure and repair whatever it is present. Because I think the main reason people are not repairing that was sometimes they say if you repair the tone and and use a bicanalicular stent, when you go through the uninvolved canaliculus, you can cause more injury than the cut, and that is why people who are not skilled in that thing, they were not using it. But now with the coming of monocanalicular stents, probably that is not a very big issue. It follows that most patients with injury to a single canaliculus will not develop epiphora. Also, older patients are more often likely to have a dry eye, so if they have some bit of epiphora, that usually helps them in a longer term. If both superior and inferior canaliculi are involved, then surgical repair is always indicated. And as I said, for oculoplastic surgeons, even monocanalicular injury needs to be repaired. Some patients will develop canalicular obstruction, stenosis, and impaired lacrimal flow, requiring additional revision surgery. So the main aim during the procedure is to go for meticulous repair and use the necessary steps which will prevent these. So medical treatment, canalicular, if there is a road traffic accident, you need to treat them with tetanus toxoid, rabies for injuries with dog bites, cat bites, or any animals, and routine antibiotics are used as well for prophylaxis. So which organism is most probably in dogs is Pasteurella canis, and Pasteurella multocida is the most common in cat. So high-risk population are predisposed to contract severe infections, so they need to be treated, especially immunocompromised patient. And surgical management, there are varieties of lacrimal stents which are now available and many approaches which can be used. The instruments utilized can be used on day-to-day on the facility you're working in. The mini monocanalicular stent has become a more popular method to repair simple monocanalicular laceration, although the stent is much more expensive than a bicanalicular stent, and bicanalicular lacerations may be repaired using a 2 mini monoca or a bicanalicular stent. The Crawford, the Rittling, or the simple stent is pretty useful in that. Going through my record, I was able to find an injury with a lacrimal stent, and this is something which I was doing with. This is something else. Canalicular tear. So this is typically a patient. I was using a pigtail stent for that, which I was not very fond of, but that day that was available, and I wanted to demonstrate that to the residents, but it worked pretty well in that patient. So this is the distal end. This is what I was saying, that you need to identify how much the proximal end is thick. And it went easily because usually these stents come in when where the tube and the metal part are swedged in, that becomes more swollen. That is slightly thicker, and when you pass through that area, it tends to get stuck in that area. And this is typically a pigtail stent which you need to go in through the healthy canaliculus and then turn it around and come up through the distal end. For this, you need to have a good anatomy and a sort of good a flow of your hands that that you are doing it in the right way, because initially when I started my training it was impossible to get this done through, but now it seemed like it was not very difficult. But you need to go up to the area where the common canaliculus is and then turn back and come through the inferior area, and then you will pass a silk suture, and then the silk suture is tied to the tube and then pulled back in that area. So now you can see this is the distal end which is here, and I'll thread a suture through this area, and the suture is pulled back. This is similar to like in a muscle hook which you use for squint surgery as well, or for in retinal detachment, in which they have a hole in that area. Now you've got the silk suture in place, and you will tie this silk suture to the tube and then pull that silk suture back, and this comes in back into place. So this is the tube which has been pulled out through the suture. So the next thing that comes in, approximation of the canaliculi as such. So you're going to do a lid tear repair as well. It's mostly useful to pass a suture through the anterior part of the canaliculus and the superior part of the canaliculus. Preferably if you have a smaller size of the 7/0 suture, that is more useful than a 6/0 suture. But if you have a 6/0 suture, then probably mostly if just you pass a superior suture through the canaliculus, that is very useful. Once you've passed those sutures in the canaliculi, probably you can leave them slightly loose and then repair your lid margin and your the anterior and the superior margin, and tie them on the end so that they are not put at traction. Because if you tie them first and then try to close your lid margin, it might cheese wire through that area. So this is the bite going through the canaliculus which I was talking about, and this goes to the superior border of the canaliculus, and in this case I was using a 6/0 suture, and this is going into the distal end. So once you've got that in place, then you can close this area. The other methods in which you can use to close this is a monocanalicular stent, in which it sort of just holds like a sink plug. You pass it through the lower canaliculus, and then when it comes to the punctum, it will there's a bulbous end over there, and it will plug that area. The other is you can use a bicanalicular stent. You can go through an inferior, like you would do a closed intubation for children, and that is something which is done pretty routinely. So these are the monocanalicular stents. So this is a monocanalicular stent. If you see over here, I'll just quickly pass. So this is a monocanalicular stent, and this is the distal end which will hook through, or this will plug that area in this. And this is the mini Manoka, and then this is the Rietling. This has got the stent and it's got a thread inside, but you can do just without a thread and do a simple stent as well. So, and the other one is a Crawford tube. So the prognosis is rarely patients require a second surgery to treat epiphora, entropion, ectropion, and generally poor lid position may necessitate further surgery. So it's something which you need to identify early, do a neat surgery, and then follow up, and you can remove the tube after 2 or 3 months' time. Thank you very much.
If any comments or questions, please, for Professor Moin, because he has to go to another session as well.
You tie, like when you tie through the tubes in the nose, you tie them to each other, and then trim them short. That is one way. The second way is you can put the tubes together and pass or sort of tie a suture around them, or pass a suture through them so that they're tied together. Third is you can use that the one for your silicone buckling, for the retinal buckling. You can put that in that area. What's की sleeve? Sorry, जी दो हैं. मेरा मतलब knot है. अगर if it is a smaller knot, it can go through that area and you can common canaliculus में ले जाते हैं. But that is an issue with this one. इसके अंदर तो preferably I don't use it that much. इस एक case था जिस वक्त कोई available नहीं था, ये easier हो रहा था. the problem in this was I was not able to identify the distal end very neatly. So distal end neatly नहीं identify हो रहा, the pigtail से neatly identify हो रहा था. That is why I had to use it. अगर वो identify हो जाए तो फिर तो सीधा मैं direct tube डाल देता हूँ, जिसमें you don't get that knot in that area.
You leave this tube for 3 months or 6 months?
3 months. इसके लिए तो 3 months पे छोड़.
3 months. Okay.
DCR के लिए फिर probably close intubate कर दूँ तो फिर साल के लिए छोड़ देता हूँ, लेकिन DCR और इनके लिए 3 months छोड़ देता हूँ. Any other question?
Sir, thank you very much. Next presentation by myself, eyelid injuries. I am Colonel Shahid, presently working as head of department, oculoplastic department at Armed Forces Institute of Ophthalmology, and my talk is on eyelid injuries. So for the eyelid injuries, you have to stick to the basic principles of repair. Examine the injuries and make sure that there is no injury which is left unfolded. That is very important, because at times we see superficial injuries and inside there are the other injuries as well. So in initial injuries, you must look for and explore for all the injuries. At times, you have to go for under general anesthesia or in the OT table, but before going for repair, make sure to explore the injuries. Then priority of repair, of course, when their patient of trauma comes to you, first is the priority goes to life, then to eye globe, and then to the eyelids. Then primary repair with the secondary, of course, the primary is the better, but there are many times we have to go for the secondary repair as well. Major reconstruction can be delayed. Operating conditions, of course, should be optimal. You must document all the injuries and preferably make diagram if possible. And before going for the repair, please remove the dirt and the debris. That will lead to the failure of your procedure, because if there is foreign bodies, debris, there will be infection and more fibrosis. So your results will not be better without removing the dirt and debris. Repositioning of the tissues is very important. You must reposition according to the anatomical structures. Now from here we start with the cases, different cases. I think that will be more interesting for you. So the first case, this is the case who had wide bear injury. He is a farmer and was working in his fields when he came across this wild bear, and leading to the injury, especially to the left side of the face. And you can imagine the force of the wild bear bite leading from the upper and the lower jaw. The upper jaw was above the orbit and the lower jaw was below the orbit. So once we got the CT scan, you can see it is not only the soft tissue injuries, but the bony orbit is involved and almost the orbital walls are shattered. So this is we removed all the debris, and we consulted the maxillofacial surgeons. Along with the maxillofacial surgeon, the orbital repair was done for the different orbital reconstruction was done, and then the eyelid injuries were repaired. So this is the post-op pic after 2 weeks, after about 4 weeks. So here you can imagine the eyeball is saved, although the orbit and the eyelid injuries were very severe. But patient has vision 6/6 even after this injury. So once you are repairing the injuries, make sure that the eyeball and the vision goes priority to the vision before going to the lids and the etc. So here another point, you can see above the eyeball, the frontal sinus is opened because of the upper jaw teeth of the bear. So that was repaired later on. And for the lower lid cicatricial ectropion, the secondary surgery was done later on. Another patient, serving soldier, he was referred from peripheral hospital to FIO, and you can see by looking superficially, you can see there is the upper lid injury for the medial off. But again, to explore the injuries, you see once you invert the eyelid, there is the injury is passing up to the lateral canthus. All the conjunctiva is involved, and you can see the tears, upper canaliculus is also involved. So as Professor Moeen already discussed, you need to repair the upper canaliculi properly with intubation. I placed monocanalicular stent in this patient. The second point is, because there is full thickness injury, you must repair the levator palpebrae superioris. You must identify the structure and repair it, because if you don't repair it, ultimately the patient will be having complete ptosis. So again, just you already seen it. So I don't know you can identify or not. This is the lateral part of the canalicular. Identification is easy, but medial one is always difficult. If you can inspect, it is very easy. But the other procedure, if you cannot, then it is the pigtail and all that. But before using the pigtail probe, please keep in mind that the tip of pigtail should not be sharp. It should be blunt. Otherwise, the canaliculi, the normal canaliculi, which will also be damaged. So this is the post-op picture after about 2 weeks, and this is after about 2 months. You can see the eyeball in the primary position, the eyelid positions, the closure is normal, and the lid, in this upper gaze, the lid can go up. So that means the levator is satisfactorily repaired. Another case with the eyelid and the orbit trauma, you can see this patient. This is with the CT scan. You can see some metallic rod going inside and passing through the orbit, lateral part of the orbit, and into the maxillary sinus and into the nasal cavity as well. So this was very easy to repair. Just remove this metallic part, and it was easy. But mentally you have to be prepared. Once you remove it, there might be bleeding from within the orbit or within the maxillary sinus. So that is the reason his nasal cavity is also packed. So this is the foreign body. Basically there was fight between two young men, and this is the screwdriver part which was left inside. Another injury, windscreen injury on the motorway, multiple superficial injuries which were repaired. The marginal along the eyelid margins, and the eyelid skin being the thin is repaired with the 7-0 Vicryl, and the peripheral where the skin is thick, these were repaired with the Proline. So this is the closer view of the repair. Again, important is to reposition the structures properly. That is very important. Do not bury the skin inside, and the subcutaneous tissue, of course, preferably should not be exposed. So this is the picture after about 4 weeks. Another patient of the road traffic accident, degloving injury. Once the wound is cleaned and the structures are repositioned, you can see this is now less horrifying, and after the repair. Another degloving injury from the motorway, and you can see the eyeball. Definitely looking at this picture, our first priority goes to the eyeball. Basically there is blood clot over the eyeball, but inside eyeball was intact. So again the wound was cleaned, and you can see here the torsorrhaphy is done, because the lids, even after repair, it was difficult to close the eyelids and to save the eyeball. So that was the reason initially it was decided to go for torsorrhaphy. Yes. So here you can see the upper lid skin is deficient. So, but the eyeball was saved with the torsorrhaphy. Later on, skin graft was applied, this one, and after 2 weeks, this is the result. So the eyeball is saved and the eyelid is repaired. So that is how you need to go for. Priority should go to the eyeball and then of course the eyelid as well. For the facial injuries, the patient was managed by the plastic surgeons. So at the end, I will just confess in front of all of you that if I know anything about the oculoplastic surgery A, B or C, it is due to one man, and he is my great teacher, Brigadier Amir Yaqub. Thank you very much. So our next speaker is Professor Tayyib Afghani. Please, sir. Topic is traumatic optic neuropathy.
Bismillah ar-Rahman ar-Rahim. Thank you very much for giving me the opportunity to talk about this. What is the definition of traumatic optic neuropathy? It is any insult to the optic nerve secondary to trauma, and it can be classified according to the site of injury, whether it at the optic nerve head, intraorbital, intracanalicular, or intracranial, or it can be classified according to the mode of injury, whether it is indirect injury or a direct injury. Direct traumatic optic neuropathy is there is significant anatomical disruption to the optic nerve. For example, a projectile penetrating the orbit at high velocity, or as a result of the optic nerve. So, just this is what you want to see. Traumatic optic neuropathy is any insult to the optic nerve secondary to trauma, and it can be classified according to the site of injury, where it occurs, and according to the mode of injury, whether it's direct or indirect. And direct traumatic optic neuropathy there is very severe anatomical disruption. For example, by a projectile penetrating the orbit at high velocity, or as a result of optic nerve avulsion. This is a case of avulsion on the right side, and you can see the fracture of the orbital wall, and which pushing on the optic nerve. Indirect traumatic optic neuropathy is transmission of forces to the optic nerve from a distant site without any overt damage. And the transmitted stress is concentrated in the region of the optic canal, whether it's canalicular or intracranial. And this is both direct and indirect mechanisms can contribute to optic nerve damage, and a clear distinction is not always possible. These are the various parts of the optic nerve which can be damaged by the trauma. Intraorbital, which is about 25 millimeter in length, intracanalicular, which is 9 millimeter in length, and intracranial, which is about 16 millimeter in length. What is the pathophysiology of traumatic optic neuropathy? A two-stage model is usually presented. Primary injury, immediate, that's immediate result. Sharing of some retinal ganglion cell axons, an irreversible process that results in neuronal loss. And secondary injury is optic nerve swelling within the tight confines leading to the compartment syndrome, and that's this two-stage model is the basis of optic nerve decompression by surgical or medical means. This picture here I have got. Yes, if you look at the upper portion, there is the optic nerve swelling, and there is just on the surface there is a small conjunctival laceration in the medial canthus. 1 month after that, this is the situation. All this is repaired, gone well, very well, but the optic nerve has gone pale. So this is it's very important to follow up these cases and also to be aware of this secondary optic nerve injury. What is the epidemiology of traumatic optic neuropathy? Prevalence. This is uncommon cause of VL loss, fortunately, following blunt or penetrating head trauma, with a reported incidence of 0.7 to 2.5%. And recent UK survey found a minimum prevalence in the general population of 1 in 1 million. And usually it occurs in young adult males in their early 30s, because most widely it's roadside accidents. What are the important causes? The most common cause of is in adults are motor vehicle and bicycle accidents, 49%, falls 27%, and assaults 13%. In the pediatric population, the majority of TON cases are secondary to falls, 50%, and road traffic accidents, 40%. What are the various diagnostic procedures? Complete history, of course, there is no alternative to that, and it has got a medico-legal consequence as well. Do not leave anything unnoticed. Rule out reversible causes like retrobulbar hematoma. Exclude associated head neck fractures. This is very important. This is a general principle. Whenever the patient comes with any injury to the face, you have to exclude all the head injury and the neck fracture, etc. If there is no indication for any neurosurgical monitoring of people, then we can go ahead with the detailed dilated fundus exam. It's very important to have extreme clinical vigilance, because as I mentioned earlier, there is always a possibility of delayed VL loss. This is optic nerve hematoma. You can see here on this side. This is the optic nerve, and this is the optic nerve hematoma. What are the clinical features and the diagnosis? RAPD, of course, would be there, and the visual acuity is quite variable. It may keep on changing or worsening. Visual field defects, impaired color vision, disc edema, especially if injury is anterior to the entry point of central retinal vessels, or completely normal fundus. This is very important. That could be completely normal fundus and optic atrophy occurring after 6 weeks. Well, neuroimaging is debatable. What is the role of neuroimaging in traumatic optic neuropathy? There is wide variation in practice. Some clinicians request CT or magnetic MRI or both for all cases. Others limit these interventions to patients with progressive visual deterioration, where the vision is continuing deteriorating, or when therapeutic interventions are being considered. One of the presenters, rule out metallic foreign body before you do MRI. CT is the best imaging modality for delineating optic canal fractures and their full extent in preparation for possible surgical intervention. However, the clinical usefulness of universal neuroimaging in TON remains debatable, as there is no consistent correlation between the finding of an optic canal fracture, the severity of VL loss, and the prognosis for VL recovery. So at the end of the day, what is the practicality of neuroimaging in all cases? It seems to be rather debatable. What are the prognostic factors for indirect? A VL recovery rate of 40 to 60% has been reported for indirect TON, and those cases which have been managed conservatively. And with baseline VL acuity being the most important predictor. It is very important baseline. That's why it's, as I mentioned earlier, we have to be very vigilant in our clinical examination. Baseline VL acuity is very important, both for the prognosis as well as for the medical legal reasons. Other poor prognostic factors include loss of consciousness, lack of VL recovery after 48 hours, and absence of VL evoked response. What is the prognosis for direct TON? Of course, it's very severe injury, and it is really, and there is a very poor prognosis for almost all cases, because it's irreversible loss and the little likelihood of recovery. Now, management is again quite debatable. Optimal management is controversial. Currently, 4 different options, whether we give systemic steroids or we carry out decompression surgery, or combination of both, or we simply observe. There have been 3 or 4 landmark studies of the last many years which have looked at the role of steroids in head injury and subset of traumatic optic neuropathy cases. One of them is called as National Acute Spinal Cord Injury Study, or NASCIS-2 and NASCIS-3. Here, the treatment regime was used within 3 to 8 hours of injury, an initial bolus dose of 30 milligram per kg, followed by an infusion at 5.4 milligram per hour for a total duration of 48 hours. So this was a mega dose. And the prognosis, the study reports that prognosis is good if treatment started within 48 hours. However, all the published case series in TON suffer from several methodological flaws. Review identified only one double-blind randomized controlled trial comparing high-dose intravenous steroids to placebo with indirect TON diagnosed within 7 days. There was no significant difference, this is important, no significant difference in the final VL outcome between these two groups having treated with megasteroids or with placebo. The major improvement, one of the reasons was a major improvement in this National Acute Spinal Cord Injury Study scores was motor and not sensory. Another landmark study is CRASH, which is corticosteroid randomization after significant head injury. That provided convincing evidence that steroids should no longer be used in patients with traumatic brain injury. So no steroids, similarly, no steroids in the subgroup of TON patients who have sustained significant head injuries. Maximum delay dose, and they also recommended that maximum daily dose, if at all it is to be given, should not exceed 1 gram. Regarding the second option, first was steroids that we have discussed, and 2 studies have debated over it. The second option is surgery. Intracranial or extracranial approach depends on our experience and surgeon's preference. There is gradual consensus on minimally invasive extracranial approaches like transethmoidal, endonasal, and sublabial approaches. An early intervention is preferable, but may not be practical due to, of course, other priorities like head injury and other systemic problems. Canal fracture repair should be done or not. Again, it's controversial. Decompressing the optic canal in this situation is unlikely to restore significant visual function. So at the end of the day, whether we should go for surgery, steroids, or observe. The next landmark study was International Optic Nerve Trauma Study, IONTS, which is the largest prospective multi-center study of TON published to date. After adjustment for baseline visual acuity, no significant differences were found between the 3 treatment groups. What are the treatment groups? Surgery, steroids, or observation. So in summary, TON can be direct or indirect, primary or secondary. Indirect TON has better chance of visual recovery, while direct has minimal. Incidence is amongst the head injury is of TON is 0.7 to 2.5%. And in adults, roadside accidents, while in children, falls are the commonest cause. RFAD is the most important sign, and baseline VN is the most important prognostic factor. NSCIS, CRASH, IONTS are 3 landmark studies that have heavily influenced the management of TON. The management remains controversial. In conclusion, there is a relatively high rate of spontaneous visual recovery in TON, especially those because from indirect trauma, and there is no convincing evidence that steroids or surgical optic nerve decompression provides any additional benefit over conservative management alone. Each case, therefore, needs to be assessed on an individual basis. Thank you very much.
first day when we received that patient was saying that he was PL negative, but there was only slight RAPD. Because the patient was saying he was PL negative, we thought maybe he's exaggerating the symptoms. But when we did the visual evoked potential, they said there is the signals are just not passing from the upward from the optic nerve. So my question is, how much time it takes for RAPD or APD to develop, even if the patient is PL negative? Or is it possible that for the first few hours, maybe, or one day, when the patient we receive, still the optic reflexes are good, even when the patient has sustained a very severe optic nerve trauma?
To be honest, I really do not know the answer to your question, but of course it depends on the type, the level of consciousness and the scoring at the time the patient presents to you. If the patient is fully conscious by all scores, what scores jo hote hain unke, us lihaaz se, then of course if there is at that time after proper checking PL is negative, I think there's very little likelihood of it being. So otherwise, if the conscious level is disturbed, of course, your method, clinical judgment will not be reliable at that time. So we should leave it for a later time. और कोई इसका इनका जवाब करण साहब कोई जवाब दे दीजिए.
Sir, thank you very much.
Thank you very much. So I have a question for you. Not a question. Just eyelid injuries is a very important subject and interesting, of course. You people at this army, of course, they come across much more devastating injuries than in the civilian setup. But what I have learned over the years in eyelid injury is that two things. First is that at times when the eyelid injuries present, the gap looks so big to an ordinary initial onlooker that they say, no, it's not possible to bridge the gap and we need to do grafting, etc., etc. At the end of the day, it's not that like that. You can easily, with some manipulation, you can pull, and orbicularis has such a elasticity, strong elasticity that the retraction is so strong that it gives a false impression of a bigger gap. It's not there. So you can always, most of the cases we were able to close without any stretch or stress. Second is, at times, especially when these eyelid injuries come at a later time, not acute injuries, the tissue misalignment is there. It's very important to closely observe which tissue is where. Sometimes I have seen part of the lower lid attached to the upper lid, and upper lid's lengthened and lower lid showing coloboma, and it's not. So we have to reconstruct afterwards, keeping in mind all these things. It's very important. This is a sort of jigsaw puzzle you have to solve, before you, sometimes you have to open the old healed chronic eyelid injuries to reconstruct it properly. Thank you very much.
Our next speaker is Professor Amir Yaqub, and sir will talk about the repair of orbital floor repair. Very important topic.
Thank you very much. Well, I'm going to briefly talk about orbital fracture, floor fracture repair. Orbital floor fractures, as you know, are of different types, and they're classified as either pure orbital blowout fractures, which only involve the floor or the medial wall of the orbit and don't involve the orbital margin, or impure orbital fractures, which involve the orbital margin as well. The most common site of fracture is the posteromedial aspect of the orbital floor, which involves the roof of the maxillary sinus. So that may or may not include the medial wall as well. The two basic mechanisms are how these orbital fractures or blowout fractures occur. They are usually due to an object striking the front of the eye, which is slightly larger than the diameter of the orbital opening. So that displaces the globe backwards and also deforms the orbital margin, and that increases the pressure inside the orbit, and that pushes out the most thinnest part of the orbital wall, which is usually the floor or sometimes the medial wall of the orbit. What are the clinical signs that you encounter in these patients? In acute, if the patient presents acutely, then there usually there is ecchymosis or hematoma. There may be subcutaneous emphysema. There is neurosensory loss in the infraorbital nerve region, and there is generally limitation of ocular mobility, especially while looking up. So the patient may complain of diplopia while looking up. But if there is a lot of edema, then these patients may not complain of diplopia in the initial stages. Once the edema settles down, then the most significant abnormality that is presents is the enophthalmos. There may be proptosis or hypoglobus, where the eye actually moves down into the maxillary sinus if the fracture is too large. Obviously, if the eye has moved downwards, then there is a deep upper lid sulcus and upper lid sulcus deformity. There may be pseudotosis. Patient may present as headaches, nausea, vomiting, or bradycardia because of the pull on the muscles. That is especially true in children who may present when they are moving the eye. They may present with bradycardia. We must first exclude any globe injuries before we turn our attention to the orbital floor repair. So all these injuries need to be excluded. So what are the indications of doing surgery in these patients? The main indication is the entrapment of tissues in the orbital floor, which cause severe diplopia, especially on looking up. The other indication is if the enophthalmos is more prominent and it's more than 2 millimeters as compared to the other eye. Or sometimes if on CT scan the fracture is too large, then you expect that these abnormalities are going to develop once the edema settles down, so you need to operate on them. So how do you approach the orbital floor? They can be a transconjunctival approach, or we can approach it through the skin. I generally prefer a transconjunctival approach because that gives a better cosmetic outcome. There are various materials that are used, and you can have once you gain experience, you can find out which works best for you. I've found that the silicone for smaller fractures and titanium plates for larger fractures are the best. Various complications that can occur after blowout fracture surgery include blindness, because if you are manipulating the orbital tissues, and that may result in orbital hemorrhage or optic nerve injury. Diplopia is generally seen in these patients almost universally following surgery, and that generally resolves once the edema of the orbit goes down. Lower lid retraction or lower lid entropion may occur if the wound is not closed properly and you include the orbital septum in your sutures, and that may result in a lower lid retraction. Implant may extrude, or there may be infection, or there may be because you are manipulating in the region of the infraorbital nerve. So infraorbital nerve anesthesia is also a common outcome of these surgeries. I'll just go through a video of this repair of the orbital floor fracture. So this patient had a severe enophthalmos, and he also had limitation of movement, especially on looking up, as you can see here. So we went in to repair it through the transconjunctival route. These are the instruments and the various plates that I preferably use. If the fracture is large, then a titanium plate is the best. So you pass a traction suture through the gray line of the lower lid, and then you do a lateral canthotomy. After crushing the tissues, you go down to the orbital margin, and once you've exposed the orbital margin, then you do a cantholysis and free the eyelid from its attachment to the orbital margin. Then you evert the lid on the Dema's retractor and make an incision just below the tarsal plate along the entire length. So you'll have a posterior flap of conjunctiva and the lower lid retractors and orbital septum, and anterior flap of skin and orbicularis. So you dissect between these two along the orbital septum, and after putting a traction suture through the conjunctiva. So you dissect bluntly between these two layers along the orbital septum and go down to the margin of the orbit, the inferior orbital margin. You can feel it through your by your finger, and you can feel the inferior orbital margin. Once you've exposed the periosteum, then you make an incision along the inferior orbital margin with the knife, and then elevate the periosteum to expose the orbital floor. Once the orbital floor is exposed, then you release the entrapped tissues by blunt dissection, being careful to monitor the pupil and the eyeball. And once you've completely elevated the tissues from the fracture, you can use these titanium plate. You can fashion them. You can adjust them according to the size of the orbital fracture, and then put them between the orbital tissues and the floor, and then apply screws to hold them along the inferior orbital margin. So these are the titanium screws, which are screwed in with without any and drilling a hole, because they are self-driving screws. So once you've placed enough screws to hold the titanium plate in place, then you close the periosteum, making sure that you don't catch the orbital septum in your sutures, and then you close the conjunctiva and as well as the canthal tendon to the lateral orbital margin. So that completes the surgery. Thank you very much.
Thank you, sir. Any questions regarding the orbital floor fracture repair, please? Comments are also most welcome.
Thank you very much, Professor Ahmed. Nice presentation. This is something which is really very common in orbital surgery. This is about, most of the times the fracture is repaired by titanium plate. Of course, sometimes the cost is prohibitive. It's not easy. It's about, how much it costs, sir?
So the plate costs around 50 to 60,000.
50 to 60,000. So we don't come across people who are millionaires. But anyway, this is a prohibitive cost. Secondly, sometimes the displacement, the fracture is not only big fracture, but there is a lot of displacement. And the volume of the orbit is increased also. That causes a lot of, that's called hypothalamus as well. And simple titanium sometimes, most of the time it covers, but at times it does not. So we have to devise a mechanism by which we can fill in that volume deficit as well as bridge the fracture. So we are doing our own technique at Al-Shifa Hospital, which I am not going to discuss at the moment, but we should consider those alternative possibilities. And secondly, what are the latest in orbital fracture repair?
That is also, as a student of orbit, we should share that. And that is, now there was some talk of three-dimensional imaging and three-dimensional modeling of the orbit. So what now is through 3D printing. There are printers available now, and the exact replica of the normal orbit is made through computer modeling, and 3D printer then gives the floor, forms the floor exactly to fit into the injured orbit. So every curve is just, is replicated, and it's just, so we just put prefabricated 3D printed orbital floor implant, and that is done. And then they also use it, now currently they use for orbital surgeries called orbital imaging, live imaging. They actually look at, there is an instrument which the imaging is done live, right, whether you are close to the optic nerve or not. So all these things combined, live imaging with computer modeling, 3D printing, the orbital floor, fracture repair has gone to our next dimension. But it's very not available in most of the places in the world. Very few, for example, in SNAC in USA, some of the centers.
And there are very few centers which are doing it. That's that sort of 3D imaging system which gives you a complete architecture of the that particular patient's orbit, and you can modify your plates or repair according to that. Thank you very much.
For shield presentation, please. Oh, Professor Abrar is not available. Yes. Thank you, sir.